Hi, everyone, and thank you all for joining us for the webinar 2 of the RCM PPM series. The webinar today is being recorded, as Caleb just shared, and it will be posted to our website. We will also send the recording and the slides to all of today's participants. My name is Latrell Courtney, and I am the Clinic Consultation Specialist with the National Rural Health Resource Center, which is providing this webinar today. And if your video feature is not on, you can do that by selecting the camera icon in the lower left corner of your screen so that you're able to see the presentation. And your audio is muted by default to avoid any background noise or feedback. So please remain muted unless you need to speak or have a question to ask. And you can unmute yourself if you're by hitting the microphone button on your screen, but if you are dialed in from your phone, you can unmute yourself by pressing *6. And also the chat box is free for you to communicate through that also. And if you haven't already, I ask that you please put your name, title, and organization in the text in the chat box so that we know who is joining us today. This helps us to keep a good feel of the audience for our webinars. The National Rural Health Resource Center is a nonprofit organization that's dedicated to sustaining and improving healthcare in rural communities. The center is the nation's leading technical assistance and knowledge center in rural health. The center has served rural hospitals, clinics, and other providers nationwide for over 25 years and has partnered with the Federal Office of Rural Health Policy for nearly 25 years, and also collaborated with Delta Regional Authority for nearly 15 years to assess rural providers and communities with their healthcare needs. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You can learn more about our commitment on our website at ruralcenter.org/DEI. Okay, we have 3 polling questions. The first one is, you can vote, according to your choice. You have from confident to unconfident to choose. I am blank in my understanding of common challenges middle revenue cycle leaders face in the industry related to social determinants of health. I am blank in my understanding of best practices for middle revenue cycle functions. And then the last one is, I am blank in my understanding of best practices for increasing organizational focus on social determinants of health. And we have the results. 11% feel confident for number 1. Number 2, 41% somewhat confident, and 44% neutral, and then 4% somewhat unconfident. Number 2, we have 19% are confident, 44% somewhat confident, 37% neutral. And then the last question, 15% confident, 41% somewhat confident, 41% neutral, and then 4% somewhat unconfident. So thank you for participating in the polls. Over the next couple of weeks, please join us for the following sessions in this revenue cycle management series. This series does qualify for ACHE continual education credits. If you would like to receive credit, Kayla will be sending out an email after completion of the webinar series in which you can fill out to receive those credits. In today's session, middle revenue cycle best practices and social determinants of health, we will review best practices that managers should attempt to implement for middle revenue cycle functions and social determinants of health in order to succeed in today's healthcare environment. It is my pleasure to introduce today's presenter, Ms. Valerie Klaus. Valerie is a member of Forvis's Healthcare Performance Advisory Services Division. She has extensive experience in utilization review and case management. Her strong clinical knowledge and understanding of government and commercial payment systems bring a practical perspective to clients. She has prior experience as a provider, clinician, utilization reviewer, and case manager. Valerie, I'm now going to turn the presentation over to you.
Thank you, Latrell. And I also have a co-presenter I'll go ahead and introduce for us. Her name is Kaylee Sherwood. And Kaylee, if you would, just give us a little bit of background for you as well, please.
Hi, I'm Kaylee Sherwood, a senior consultant with Forbes. I have been doing, I have about 15 years in revenue cycle experience, with my latest being in a large academic medical center doing coding and compliance.
Thank you. Well, we'll go ahead and go over today's agenda. Today's agenda, we're going to be talking about your HCC best practices for your providers. Kaylee has some wonderful examples and case studies that she'll be chatting through that really gives a visualization of how the HCC and risk adjustment is driven by the documentation as well as proper coding. And then we'll go on to talk about the social determinants of health and an overview of that and how it affects your pay for performance, and then some implementation considerations at the end. In today's objectives, we want you, when we're all done here, to have a greater understanding of the clinical documentation and then diagnosis coding and how it affects your accountable care organizations, and then flows back into that HCC and risk adjustment. Have a better understanding of best practices for capturing the appropriate HCC and your weighted conditions annually. And that's one thing that we cannot drive home enough in today's conversation, is that once you've captured the HCC risk adjustment, you're not one and done. It's an annual endeavor to make sure that we are doing that at least once a year to capture that true health of the patient and truly paint a picture of it. And then we'll also work towards the social determinants of health. And as we go through that section, Kaylee will be able to give us some commentary on the coding and how that coding affects the HCC risk adjustment on those social determinants of health. And then also have a better impact of those social determinants of health on your patient's health and well-being. As clinicians, a lot of us are trained to help get people better. And so talking to your patients about staying well and their well-being is a different conversation that providers are needing to embrace. And that's one of the areas we'll be talking about. And then we'll also talk about the screenings for social determinants of health. There's a lot of portals coming at your patients, be it through your EMR, through their payers, and then truly utilizing that information and respecting the information as it's coming through, because a lot of it is rather sensitive. And then flowing into that critical role of the local community partnerships in serving the patients. Kaylee, I'll go ahead and hand it off to you for the definition and kind of working through those that beginning section of the HCC best practices for the providers.
Thanks, Val. So we'll just go ahead and jump right in. And let's talk about an introduction to risk adjustment. So risk adjustment is the process of modifying payments and benchmarks to reflect degrees of illness or disease. It then allows CMS to estimate future spending, potential adverse outcomes, and allows providers to understand the health characteristics of and manage their population or patient cohort. So diagnoses really need to be supported in the documentation. Not all diagnoses map to an HCC. If you see a patient for a certain diagnosis, but you're not documenting that, then, obviously no credit's going to be given. Risk adjustment really is used as a prospective payment model and reflects patient acuity. So risk adjustment, Val, if you want to hit that next slide.
Mm-hmm.
Risk adjustment methodologies, who uses this? This is a CMS quality measure through value-based purchasing. Medicare Advantage also uses it, ACOs, and the Affordable Care Act. So those health insurances that you find through the exchanges. So HCC is an acronym for hierarchical condition categories. There are 86 categories with over 9,500 codes, give or take. Again, it is a model originally designated to estimate future healthcare costs for patients. And each one of those HCCs is given a RAF, which is a risk adjustment factor score. And diseases tend to roll up in hierarchy. Beginning the start of last year, so January 1st, 2022, CMS did change the way HCCs are captured. Only outpatient encounters will be used for risk adjustment instead of risk adjustment processing systems and inpatient claims. So that was one of the major moves just recently. There are conditions, and it is so hard to capture each and every condition, especially, most doctors work in 15, 20-minute time frames, but there are often ones that are consistently missed that actually do map to an HCC that do have RAF scores. Number one on the list, amputations, AFibs, chronic respiratory failure, things like CKD that don't, that the stages aren't linked, diabetes with complications, malnutrition, morbid obesity, just to name a few. So what does the coding and documentation need to look like for these HCCs? HCCs must be redocumented annually. So the patient starts with a clean slate every January. Annual wellness visits, absolutely the greatest opportunity to capture those ACCs or HCCs. And capturing the diagnosis to its highest specificity. So bronchitis is not an HCC, but we see that chronic bronchitis does map to an HCC. Again, chronic kidney disease, left on its own, does not map to an HCC, but put with a stage 3 and above, it maps to an HCC. So it's going to get those RAF scores. Diagnoses must have evidence of an acronym that we like to call MEET. Monitoring, evaluating, assess, and treat. And there is no such thing as over-reporting a diagnosis. So if it's relevant to that encounter, then you can report it as many times as needed throughout your year, or as long as you see the patient. So again, to avoid the falling off, we need to recapture. About 50% of current year diseases come from the same HCC categories captured in the prior year. Anywhere from 30 to 40% of the prior year's diseases for active patients are missing in subsequent years. So although they still may be having that same disease or chronic illness, it's not getting reported year after year. Patients with new diagnoses, we can add or move or even remove the HCC from the prior year, depending on how they're progressing within their disease. And really leveraging your EHR systems to make sure that you're capturing the HCCs on a yearly basis is key with most clinics. So as I mentioned prior, we have this great acronym that we like to call MEET in the coding world. It is management, evaluate, assessment, and treat. This is how you're going to link your diagnosis through documentation. So you can see the management. We're doing disease progression, disease regression, which way is it moving? How are the medications? Signs and symptoms, things of that manner. the evaluation, again, medications, are they doing anything? Should we look over test results, effectiveness, things of that nature? And then the assessment, what do we do from here to eventually get to our final treatment for this chronic disease?
And Kaylee, you brought in some great information, especially when we start talking about documentation. And this is where we can really hone back in and have those conversations with our providers, be it through the clinical documentation specialists or through the coding and billing world, helping the providers stay engaged and continue giving them proactive education around HCCs. I can tell you from a provider standpoint, prior to having introduced to me through my billers, never heard of it. It's not something they cover in school. And then also, keeping those provider involvements on the problem list and other, form development. The problem list, we hear time and time again from our clients that, it's not being updated because we either A, don't have time, or B, it's just become so voluminous. We just add to it, we don't take away from it. Well, that can pose a problem, especially when you're trying to capture your HCCs. You can have patients with different stages of kidney disease, where all of them have been captured. We've had patients we've seen in our chart reviews where they've had type 1 and type 2 of diabetes, depending on who entered in the information regarding that patient. So those problem lists can get rather hairy. And as you're trying to capture that information for your patients, really can make it more of a problem. So truly keeping that provider engagement, and whether it be the scribe or the provider, go in and truly get those problem lists up to date as to where they need to be. And then embedded HCC management tools in the workflow, again, having them accessible to the provider at point of care. A lot of the EMRs have that essentially click and play. So, make sure you use it to your advantage. So that way, as the providers are doing their assessment, their documentation, they're able to then go in and capture those HCCs and get, the right stage of kidney disease and the right type of diabetes captured. The goal is then to, have informed decision-making without additional clicks. All of us within our jobs have, that constant where we're filling out forms. And so there can be that click fatigue to where, hey, you know what, I just need to get in my physical assessment, my plan of care for the patient, and then it just becomes one more thing. So, making it as efficient as possible and have the providers be part of that form creating and development. And then also, send your cases through a coding staff queue. Rely on your coders. And we hear this time and time again from our providers, we are not coders. However, we are documenters, be it a physician, nurse practitioner, or physician's assistant. And we essentially are the ones who know our patient the best. So we truly need to make our documentation match the story of that patient's health. That in turn will then make it easier for the coding staff to then code what we have provided, what care we provided for our patient. And then to ensure accurate coding, again, it flows back to that documentation. The documentation as it enters the EMR will then flow into the coding and then all the its way down into the bill. So, ensuring that the patient is seen each calendar year to make that accurate coding. Has the patient's health changed? As Kaylee had reported, only about 50% of that data makes it on year after year. And so you truly need to make sure we're going back in and capturing those chronics, the amputations, the transplants, the items that we know cannot be undone, and it is following the patient throughout life. Continue to build your clinical dashboard. That'll provide a snapshot of both the EMR and the claims data. Being able to have that reconciliation each calendar year will help you make sure you have that complete picture of your patient. And then once identified, match those with both the visit and your HCC coding gaps. That is something that is really important to make sure that you are not only capturing, that visit stay information, but also that coding gap and the remediation that will need to be done to then make sure that it is flowing through all patient care and all of that coding that goes with it. And then also acquire your information at the system, region, clinic and the provider level on those dashboards, and review those at a minimum a quarterly basis. I just left a clinic site with a patient's, with a client of ours, and they are reviewing, especially at the beginning of the year, on a monthly basis. So just truly making sure we are getting that accurate information in. And then best practices, or leading practices, as I like to call them. You know, front load the visit. You know your patient is coming in on that day of your visit, what you can pre-chart. Make sure you're getting in that information regarding the patient's chronic issues that you know are not going to change. And then you can add to that as you're having your clinical visit. And then looking at your coding and documentation guidelines, you know, what can your providers do to impact your risk adjustment score? You know, help have a understanding for a need of better documentation on every encounter. It is so easy to get lost in the weeds, or just lost in your voluminous schedule of patients and your quick turnaround of your rooms to keep your patients on time, but as well as your schedule, you know, so you complete your time. So being able to identify at the admission or at the, you know, check-in of the encounter, what are those items, those documentation pieces that we can add? And further into this slide, you know, remembering that the diagnoses that are staged. You know, are we putting our stage 3, 4, and 5 of our chronic kidney disease? Because those are the ones that will affect our HCC. Asking coding and CDI and IT to help review your templates. Helping your physicians get a pick list of more specific items, because coding to your highest specificity is what will ultimately affect your HCC and then that RAF scoring, as Kaylee had talked about. And then also making sure that you're taking credit, you review and you reconcile your medications on the list as they are prescribed, especially for those chronic conditions. That is one thing, as long as the problem list is, you know, the medication reconciliation, making sure those are done at every visit, be it as minor as the visit may be, or as voluminous as it might be for a chronic review of conditions. And using your most specific codes for those diagnoses. And then looking at our top Medicare risk adjustment errors, as Kaylee had mentioned, you know, those items that are omitted, you know, from that HCC risk adjustment frequently, you know, looking at the risk adjustment error as a whole. You know, the health record does not have a legible signature or credentials on or the EMR was not authenticated. We don't see so much in the signature realm anymore, because everybody has moved to the EMR, but there are still some facilities that are paper charting, or when we have those unfortunate downtimes, making sure we're capturing those signatures. But then also the EHR, making sure that we have an authenticated electronic signature for each visit. And then also, again, lacking the specificity. Oops, let me get this back here. There we go. Lacking the specificity, such as your unspecified arrhythmias versus a specific type of arrhythmia, or a highest degree of specificity was not assigned to the diagnosis. When we have it just partially there, and you'll see this in some of Kaylee's examples that she's going to share with us, you can get a little bit down the road, or you can get all the way down the road and truly have a book of truth of that full patient's health. And then having the required linking language, the causal relationship or the manifestation codes are missing. The documentation, here's another error rate that is pretty common. The documentation does not indicate a condition as being managed or monitored or evaluated or assessed or addressed or treated during the visit. You know, we'll see this sometimes in our chart assessments, where we'll see at the end a whole laundry list of diagnoses, but there isn't any meat to those. We don't know how that chronic hypertension is being managed. It's just listed there. So we truly, if we're going to list a diagnosis, be able to then document how we're managing it or monitoring it, how it was evaluated, how it was addressed, and then how it is currently being treated. And again, the discrepancies again between your billed diagnosis and the actual description of the condition. And this rolls right back up into that meat. If we're not able to draw a line between the billed diagnosis and what is actually being treated, it makes it really difficult to do any type of adjustment on that, because it can't go through that risk adjustment scoring. And then this is a large one, the cancer status that is unclear because treatment is not documented. This will be covered in Kaylee's example, but that history of cancer will roll into the HCC risk adjustment. So it may not be something that's currently being treated, but truly mentioning it in that meet category. It doesn't say that there is treatment. You are documenting what the treatment is. And currently for that cancer, there may be none. However, it is still an active part of the patient's diagnosis history. And then chronic conditions such as your hepatitis not being documented as chronic. So we have those diagnoses such as, bronchitis or hepatitis, where we have chronics and we have acute. So truly, if it is a chronic condition, document it as such. And this last bullet point flows within that as well, truly having an annual basis of those chronic conditions documented. And Kaylee, I'll hand it back over to you now with some of those wonderful case studies.
Thanks, Val.
You bet.
Okay, let's jump right into some examples and case studies like Val was talking about. So the first example I have pulled here, make mine a little bit bigger, sorry. This is going to touch on diabetes. So the specificity of the diabetes and how when left unspecified, that E11.9, that doesn't map to anything. So what do you need to have as far as the linkage, the meat, things like that? So for this example, this is a diabetic patient being seen as a follow-up. We know that the patient has hyperglycemia, fasting blood sugars in the office. We did the HbA1c count is 9.2. Patient's insulin regimen was adjusted, patient's counseled. So down in the documentation example, we have hyperglycemia. Labs were interpreted. Diabetic counseling was performed. We even have a referral to a dietitian, and her insulin regimen was adjusted. So if we go out and we're looking for codes, how are we going to code this? Well, diabetes left at E11.9 isn't going to be enough because we know that this patient has hyperglycemia, and there is a diagnosis code, that E11.65 is diabetes with hyperglycemia. And then you would also code for that long-term insulin usage status, that Z79.4. We go into our next example, and Val, thanks for mentioning hypertension before, because this is a great example of isolated hypertension does not map to an HCC category, therefore it has no RAF score. If that relationship is documented between hypertension, congestive heart failure, hypertension, CKD in a stage, etc., you see that we have that row that says 85, 136, those are where the HCC category is. And then the row there to would be my right, that 0.323, 0.237, etc. down, that's the actual RAF score when you link the relationship of diseases instead of just leaving that hypertension as isolated. So this next example is interesting because if you notice, just being entitled for Medicare gives you a RAF score with no other diagnosis links. But if we have partial diagnosis, so partial documentation, we see that congestive heart failure, COPD, was mentioned. Those have HCC categories linked to them both. Therefore, it is pulling a RAF score. And you can see at the bottom of example number 2, that patient just with those two diagnoses has a RAF score of 1.666. Now, example 3, we take that same patient and we complete the documentation to its entirety. So not only are we dealing with congestive heart failure, COPD, also has diabetes with complications, and has a lower limb amputation. Both also map to an HCC category. Both have a RAF score attached to it. So he just climbed, this 76-year-old patient just climbed from a 1, in example 1, to a 2.487 RAF score by the end of example 3, giving complete documentation. So again, this is just another example of complete documentation, not leaving anything to an unspecified diagnosis. So diabetic patient with COPD, congestive heart failure, is being seen for a follow-up. It says that in this documentation, the patient's counseling was performed and recommendations were discussed. Medication was reviewed, a referral to a pulmonologist was given, and there was amputation status. So as a coder, you're going to go through and code. Again, diabetes is not left unspecified. We've got E11.65. We've got long-term insulin use. We've got the COPD. We've got this CHF. We've got lower extremity amputation status code there.
And this next one is my favorite, Kaylee. It really,
I know. I was
always
just
has our
thinking that we should have left the red text out because that's my favorite way to present it. So usually we present this and it's all black text. And this is supposed to be an example of a shortened for time purposes clinical note for a doctor, completely hypothetical. And then we switch to the this slide here where everything's in red, because it really does, when it comes through a coder's desk, this is what we see. We are pulling all of these little bits and pieces out of this documentation and linking those, all of these things back to the diagnoses that the provider has provided us. So again, really making sure that that acronym, that MEET acronym is met. So when we map this, then, Val, if you want to go to the next slide.
Absolutely. And just we'll pause for a second before we go to this next slide. Those of you out there in the practice manager space, this is a great sample or example to share with your providers when you're talking about, documentation to the specificity. Definitely, and these slides will be available through Latrell and team. But being able to share this with your providers to let them know that that documentation really matters, and it definitely carries some weight, as especially in this next part of the example that Kaylee is going to share with you. There you go.
Thank you.
You
So
bet.
you see, we took that that shortened example, and the 65-year-old female who is community-based with no chronic conditions, that first column there, that 0.321 is her RAF score. But we know, based off of that prior slide, that she is breast cancer with RX, with a prescription. So that's adding that 0.153, and that's lifting her RAF score. But we also know that she's COPD. She's a 20-pack, prior 20-pack year smoker, has a maintenance inhaler for her advanced lung disease. So we've got that, then the COPD lifting that RAF score. If you make your way down those columns, malnutrition, her BMI 17. So that malnutrition RAF score is 0.554. She is now at a total RAF score of 1.363. And I do have the bottom column there is the estimated predicted annual cost of this patient. So we know that her AFib is controlled, lifting her RAF score again. And she's got A1C was a 7.4, and she's got complications, numbness and burning with the lower extremities. So again, that's now adding a RAF score. So she went from a 0.321, and by the end of this complete documentation, she is at a 1.941 with a predicted annual cost of $18,148. So this is how important it is to make sure that you are capturing each diagnosis to its highest specificity and really putting the book of truth to your patient's medical record.
Thanks, Kaylee. Now, those are great examples, and being able to put that in such an applicable visual that really works. Thank you. Next, we're going to move on to the social determinants of health and overview. And so, before I start, I want to go into, just what created the social determinants of health initiative. The United States spends far too much on healthcare, and we have a higher cost of healthcare than most countries. And so out of that continuous spending over the last 3 decades, has come in the importance of these social determinants of health. Being able to essentially look at creating health, as I had mentioned at the beginning, instead of treating health. Being able to, look at the care process, the administrative efficiency of the care delivery, the equity of the care delivery. The United States ranks last in equity, with differences related to lower to higher income in adults, and also related to timeliness, the financial barriers to care, and patient-centered care. The health outcomes, the US also ranks last in infant mortality, which as a provider, that one just really hit home. It's like, how can such a well-developed country rank last in infant mortality, as well as life expectancy? Life expectancy is 83.1 years, but it's declined in the last 2 years. And then also deaths that were preventable with timely access to effective healthcare. Kind of diving more into this rising cost of healthcare, patients aren't going in for problems due to high deductible plans, but they're just delaying care. They're delaying care in the fact of cost. The point of this slide is to not only, what does the health system why are we not producing health, but it is also hurting us, particularly financially. Our out-of-pocket costs are bankrupting families, and people don't even seek care anymore because they just can't afford it. And this is something that I experienced quite a bit when I was practicing as a nurse practitioner. Found myself looking to see, okay, what drug seminars can I listen to be able to get affordable insulin for my patients? How many drug reps can I listen to be able to fill my refrigerator full of samples of diabetic medications to keep my patients covered? And I know a lot of providers are in that space doing that, and a lot of clinics as well. The US, the healthcare spending grew from 9.7% in 2020, reaching $4.1 trillion, or $12,530 per person, which accounted for a 19.7% across the nation of gross domestic product. Letting that kind of sink in, it's like post-pandemic, we're looking at these numbers, and it just is astounding. Jumping into the conversation of what creates health. This is the most widely accepted model of what creates health today. It was created by UW Population Health Institute. The county health rankings in this model illustrate a board vision for health. The model shows that policies and programs at a local, state, and federal level play an important role. and shaping the health factors that in turn will then influence a community's health outcomes. The health factors represent things that are, if modified, can improve health length, and also quality of life. They can also affect the predictors of how healthy a community can be in the future. So we're looking not only at the patient level, but more of an umbrella of the community level. The 4 health factors and areas in the model include health behaviors, clinic care, social and economic factors, and physical environment. The health outcomes represent how healthy a community is right now. They reflect the physical and mental well-being of the residents throughout measures representing the length and quality of life typically experienced in that community. When you look at what creates health, clinic care is only 20%. Social and economic factors are 50%, and behavioral health is 30%. In summary, 80% of what creates health is impacted by your social, economic, and behavioral factors. Healthcare doesn't stop at the clinic or the hospital doors. It's much larger continuum than it's typically given credit for. It begins on what's happening in our lives every day, in our homes, our schools, our workplaces, and even in places of worship. There are quite a few health community nurses that will practice and are available within congregations to help in this space as well. And then just going back to that conversation of just, what are social determinants of health? The World Health Organization defines social determinants as conditions in which people are born, grow, live, work, and age. Social determinants are shaped by the distribution of money and power and resources of individuals. And they also are primary drivers to poor health outcomes, disabilities, health disparities, and early death in the United States. Common social risk factors revolve around food insecurities, housing instability, transportation needs, financial resource strain, and social connections. The food insecurities, those will either help or hinder those chronic conditions. The housing instability puts patients at risk of those chronic health conditions being unmanaged due to the fact of the patients needing to focus on what currently is the need, which is housing. And then the transportation needs at a clinic level, I witnessed time and time again the inability to attend an appointment, or after being able to attend the appointment, being able to then obtain the medications that were prescribed at the appointment or the therapies or treatments. And that rolls all the way down into that financial strain as well as the social connections. Health equity. Healthy People 2022 defined health equity as the attainment of the highest level of health for all people. And as a community and as a provider, that is something you wish and you hope for all your patients. 10.4% of the population was experiencing food insecurity at the time of this information gathering. At 13% of the population did not own vehicles. 17% of the households had severe housing problems, and 6.3% of the population were unemployed. And that as a whole would then roll into roughly the unemployment was 20,941,430 people were unemployed at the time of this Healthy People 2022 survey. That alone will roll back into a social determinant of health factor for your patients and even just getting to the appointment. The common behavior factors that rolled into the Healthy 2022 survey rolled into the physical activity, stress, depression, tobacco abuse, alcohol abuse, and intimate partner violence. Post-pandemic, the alcohol abuse, tobacco abuse, and intimate partner violence has gone up due to the amount of social and financial stressors in the household. So being able to talk to your patients and making sure not only are they with you at the appointment, but also be assessing and screening for these common behavioral health factors that will not only impact the patient's health, but then also their ability to come back and continue the services at your practice. The social determinants of health impact on value-based care. All of this rolls back into that conversation we have when how is this affecting, you know, your HCC risk adjustment scoring? And we'll kind of go through a little bit further in this next slides, the next couple slides on why it matters, and then also the impact of collecting this data. The social determinants of health impacts lives of every individual in all the communities at large. Awareness of your social, economic, cultural, and geographic differences may allow the U.S. to provide some culturally competent care and to minimize your health disparities. As a healthcare professional, you know, we are in a unique position to then advocate for our community members, our patients that we serve by understanding what these drivers are to these health outcomes. And then at a patient level, have an understanding, help them understand that there are unique sets of barriers and circumstances that may influence the care that we can provide and ultimately, you know, affect the effectiveness of our care. Sometimes the patients are stuck in the situation to where they don't see how just their situation alone is impacting their entire health. And as a provider, that is something you want to make sure that you're bringing home to them. You know, the future state, when we're looking at social determinants of health, healthcare insurance, as well as quality factors have come out of this. The social determinants of health screening with future payer contracts, those have shown up, especially in the Medicaid, Medicare Advantage. We're seeing that. As Kaylee spoke earlier in that ACO space, social determinants of health will play into that. And then also the quality scoring, process and outcome metrics and evaluation. Being able to use the social determinants of health to, you know, look at the quality scoring of the impact on the community, the ability to target resources to lower overall total cost of care, improving patient outcomes, and also improving overall health of our community. Implementation considerations when we're looking at the social determinants of health. It's like, we've got all this information, what are we going to do with it? The social determinant of health screenings should be completed annually at wellness visits and annual wellness exams. So at least once every 365 days, or as warranted by the patient's needs. The social determinant of health screenings are available to all members of the care team, be it your ED staff, your inpatient staff, specialists, care coordinators, your case managers. Having those screenings available so that anyone can complete that screening at any time helps further that information collection of data to then help further the care for your community.
And Val, I just want to say, as far as these screening considerations, you know, every organization's different. I think that, you know, really building a tool to help your patient feel safe that they can then disclose this information. So then you are capturing those screening codes is very important, you know, to consider, you know, who is this going to be administered by? Is there someone in your organization that works with the community that can help facilitate these types of screenings? You know, can you refer to community resources, things of that nature? But most importantly, making sure that, you know, they even feel safe enough to disclose some of this information, so that way it is captured within their chart, and then you guys are helping them and supporting them in their needs.
No, that's a great point, Kaylee. And then also when they're capturing the social determinants of health, what are the codes or the coding section that they should be looking towards?
Yeah, if you want to jump to that next slide, Val.
Absolutely. There you go.
All right, so this is just, you know, for time purposes, it is going to be those Z codes, 55, through Z65. So for example, Z59 is problems related to housing or economic circumstances. Z62 is inadequate parental supervision. They have one for an overprotective parent, upbringing away from parents, Z62.2. You're always going to capture your tobacco usage with, nicotine or tobacco dependence, but also that Z72 is just tobacco use. So those Z codes are going to be really important to make sure they're making them onto your encounters that you're appropriately capturing for these social determinants of health.
Thank you, Kaylee. Yes, that is definitely something we want to make sure that as you are finding out about these social determinants of health, as we talked about earlier, being able to not only document them within the patient's chart, but then have them flow into those codes that will ultimately affect that scoring. And as Kaylee had talked about the sensitivity, there are several avenues where this information can be collected, prior to visit through the patient portals, be it MyChart or any of the other EMRs with those patient portals. At check-in, we have several clients who will provide an iPad at check-in or some type of electronic device with that questionnaire so the patient can privately go through those questions and it goes back into the chart. And then also during the appointment with a trusted care team member going through those questions and being able to accurately capture those, which will then accurately at the end be able to provide that information to the provider in the clinic office to be able to get the patient the absolute most effective care. And then just like with any protected information, making sure that the patient sensitivity is respected as you're collecting this information that is very sensitive to the patient. It is their personal mental and financial well-being that typically will flow into these social determinant of health answers. And then Kaylee has a little bit of information on this last slide. I'll let her kind of chat this through, but it's really looking at that social needs solution board. Kaylee, if you can you explain that?
Yeah, so we have just seen with prior clients putting together like a multidisciplinary board to assist in capturing population health information that can give a little bit of direction on how to use the information from a positive effect within your organization. Just to really drill down the needs of your patients and what you can then give back to them. You can use this board for brainstorming ways to, capturing the social determinants of health first and foremost. And then once you have a good idea of your population health and your patient cohort, really drilling down, what it is, what assistance that you can provide as an organization, for these patients. And it's just, we recommend a multidisciplinary just because, you see different needs in different stages of the organization, from front desk all the way to, physician. There's definitely different realizations there.
Thank you. Well, and that takes us to the end of our presentation. Are there any questions?
So I do see a question out there. So does coding HCC and social determinants of health raise the E&M code level for higher reimbursement? So your E&M code level is going to be your fee for service. That is whatever is going to be negotiated between you and your insurance provider. HCC from a value-based perspective is the way of the future. That's just the best way to put it. They are really wanting HCC to be more of a preventative than a, patient came in and now we're treating symptoms, signs and symptoms, like a fee for schedule model tends to do. So your HCC for value-based, those RAF scores that I was talking about, and then that predicted cost that is reflected within those RAF scores, eventually, what is going to happen is like a shared cost savings, and that is how they're going to be paying out HCCs. They're basically going to be rewarding you for getting those diagnosis codes to the highest specificity so they can predict the cost for that patient. Social determinants of health aren't necessarily going to be reimbursable, but what they do is they help predict that model as well. So as Val was saying back on slide 31, common behavioral factors, the physical activity, the stress, the depression, alcohol abuse, tobacco abuse, intimate partner violence. So we know tobacco use increases risk for disease and disability. So it's really projecting what could this patient, who seemingly could have nothing wrong with them today, but 5 years down the road, what could that look like based on their tobacco usage, based on their alcohol usage, based on their stress levels, etc. So not necessarily reimbursing, but definitely used to predict health. I hope that helped.
Thank you, Kaylee. Latrell, we'll hand it back over to you now.
Yes, so thank you, ladies, for your time and leadership today. Before we conclude the webinar, we would like to gauge everyone's feelings about the webinar. We have 4 questions. I am blanking my understanding of common challenges middle revenue cycles leaders face in the industry related to social determinants of health. I am blanking my understanding of best practices for middle revenue cycle functions. I'm blanking my understanding of best practices for increasing organizational focus on social determinants of health. And I almost blanked the last question that I will apply the knowledge gained from this educational training to measure my organization's internal performance related to RCM PPM. Okay, and the results up on the screen now for each of the questions. So thank you all. Thank you again, Valerie and Kelly, for your time and expertise. Also, thank you to all the Delta program participants for joining us. I hope you found this session beneficial. And as always, please do not hesitate to reach out to us at the center with any additional questions. We hope you all will join us again next week for the final session. It'll be the physician practice management best practices. And so hope to see you all there next week. And I hope everyone has a great day.
Thank you, Latrell.